Well, welcome everybody to another 1 hour CE course. We do try to set it up so that every year one of the services we provide you is CE that pertains to things that you probably won't get anyplace else. And that's one of these courses. And we're hoping that we're setting these things out there on YouTube, and you can also access them on the MedicarePlanDetails.com. So today we are having a presentation mostly by Bob. We're going to be going over some things on the Medicare. We did change this at the last minute a little bit because of the first draft of the final rule that came out for Medicare. So we're going to be discussing that. And I think that will probably generate some questions. I think that many of you are probably going to be asking how it's going to affect you, what's going to affect, because we are expecting, at least I'm expecting, and I believe a lot of other people are expecting, that this year is going to be a sea change in Medicare. There's more changes to what's happening. We're going to see that in the premiums that are charged. I believe we're going to see many of the $0 premiums have a premium this year. I believe that we're going to see a decline in the value of the benefits this year. I believe that we're seeing changes in compensation. We're seeing changes in marketing regulations. We're seeing changes in how the carriers interrelate with the agents. And so we're going to be discussing some of those things here today. This is a CE, so that means that Nancy will be sending out 3 questions to you at the end. We need to get those answers back before we can report to CERCON that you've attended and paid attention to the CE that we're going to have done. It's going to be mostly presented by Bob. He's asked me to step in and talk about some things. And so I'm gonna be doing that every now and then. So, Bob, take it away. You're on mute, Bob.
I'm still getting quite a bit of feedback from Terry.
I don't know why, because I've turned off her mic.
Yeah, I'm getting a lot of feedback from Terry. So I'm not sure what that is. But anyway, let's get going. I just want
maybe Terry could log out and log in again.
That we really would like to have a lot of discussion, and that you jump in with your thoughts and ideas. I'm going to turn down my sound a little bit. I hope you can still hear me. I don't think that affects the microphone, does it, Doug?
No, I can hear you fine.
Oh my goodness! There we go. A lot of shakeup in the national markets this last year. Additional numbers and observations we're going to get into here in a minute, but there was also disruption in the Utah market with Regents exiting their zero premium plans and Cigna issues, and then we had CVS/Aetna aggressively have a very aggressive benefit design. That $1,200 healthy living direct reimbursement benefit, and they're still having some ongoing issues with some contracting you might be aware of, and also Select Health came through with that Kroger plan. The Kroger discounts, the pharmacy benefit, the OTC, and the monthly extras. Next slide. Here we go. This is from Baltimore Health Analytics, which I think is very interesting. The real shocker here was at the top, you see United Healthcare grew 1%. Humana 12%, but the big one was CVS/Aetna. They had a 15% increase in their numbers, and you can see the actual numbers in the two columns to the left. We also have other ones. You can see Kaiser Foundation was flat, which is interesting. They've been a 5-star plan in California for years, so that was very interesting. You see the Cigna Group minus 1% growth, Scan minus 2%, and I don't know who MH Healthcare is. I'm sure that's a regional plan just by looking at the numbers. Next slide, Doug. Okay, this is just an extension of the previous one. If we come down here, you can see some Blue Cross Blue Shield plans that one in Tennessee had decent one. The big one here that affected a lot of us here in Utah is the Molina Healthcare, minus 7%. We've got Alignment Healthcare, which is again another regional player, at 2% growth. And then as we go down, you can see others. There's some Blue Cross Shield down here, minus. Well, they had an 8% in Carolina, but you can see others in here were pretty flat. Next slide, Doug.
Okay, so Bob's asked me to jump in here and talk about some of the things that are causing disruption. Can you guys hear me? I know Bob was cutting out. His sound was cutting out on me. Are you able to hear me?
We can hear you fine, Doug. Bob was terrible.
Okay.
Yeah, we can hear
Okay.
you.
Okay.
I don't know how we fix the feedback, but there's a lot of feedback.
I don't either. We've got some real technology. Can you turn your mic on and off, Bob, and let's see if that helps? Okay, so let's take a look at some of the things that are happening this year right now and that are contributing to the shakeup that Bob was mentioning. One of them, and many of them have been initiated by the declining government reimbursement rates to carriers. They're going to go down for the second year in a row. They're only going down by about 0.2%, but it's causing some major difficulties with the carriers. They are all under extreme financial pressure. The industry itself is under extreme financial pressure right now for a number of reasons. And we're going to talk about some of those reasons. And so we think that you need to be prepared and start thinking about how you're going to handle 2025 going forward, because it's going to be, like I said, a sea change. I think that we're going to get into some of the things that are happening. We're just going to be feeding them piecemeal to you. One of the things is that we anticipate plan design changes. And by the way, this is not us. These are the financial analysts that are anticipating these things as they talk with the financial people at the different carriers. So some of the things that we think are going to be happening is that plan designs are going to be changed. And some of the carriers are going to focus on membership growth. Some of the carriers are going to focus on membership retention. We also think that a lot of the growth in the supplemental benefits that we've seen in past years, like exercise programs, dental, vision, and hearing, and everything, is going to be refocused back on healthcare, or the major component of healthcare rather than the ancillary components of healthcare. The financial analysts are anticipating that we're going to be receiving new narratives from the carriers about why we should pay attention to them and pay attention to their products. The new narratives are going to be going out to providers, agents, and beneficiaries. They're anticipating that in the future, even though we only have one C-SNP right now in the state of Utah, the growth in C-SNPs is outpacing the growth in D-SNPs, even though the growth in D-SNPs is not meeting expectations. There's a lot of opportunity for growth there. If people could, if agents could figure out how to manage the section in such a way that the benefits outweigh the costs, and the costs have to do with the behavior of the clients who are eligible for D-SNPs. Anyway, don't know quite how to handle that one, but there is a lot of opportunity for growth there if you can do it. CMS is, and Bob is going to talk to you a little bit down the road about some of the things that CMS is hoping to do. One of the things I'd like to mention right here is that CMS is trying to get it so that MA carriers pay for obesity drugs. And they're hoping that this will reduce the cost of heart attack and stroke incidences. But it is stuck in Congress. Congress thinks it might cost too much. And so that's currently happening. Gene, you raised your hand. Did you want to say something?
Yeah, while you were still on the CSIP DSNP thing, I don't know about nationwide, but here in the state of Utah, DSNPs are probably under pressure because the state of Utah is reducing the number of people that they're qualifying as a dual eligible. So as the numbers of Medicaid patients are reduced by the state, that's going to impact your DSNP.
Yes, a lot of that reduction was a response to the COVID, where they did not cast anybody out of Medicaid during that whole time. So they were on there for, I don't know, 2 or 3 years, contrary to what happened before. And so they're coming through and they were casting everybody out. There was as many as they were anticipating, anywhere from 40 to 60% of Medicaid beneficiaries to be thrown out of the program. And that was supposed to trigger reapplications. Lots of the people who were thrown out have not reapplied. I don't know how that's going to get worked out. But thanks for bringing that up, Gene. There are other aspects that also Bob is going to talk about here. And these things have put the entire healthcare distribution system at risk this year. CMS is really worried about that risk. We have physician groups that are going bankrupt, hospitals that are going bankrupt, and Bob's going to talk about that a little bit more. Lots of people are being laid off at the hospitals that are not going bankrupt. We don't have enough healthcare workers, and yet we're laying off nurses and doctors and clinicians and everything all around the country because of the challenges of the situation that we're in. And by the way, I don't want to make this too tough. I'm trying to prepare you for what's happening without being well, I got someone on here named Debbie, so I can't use what I was gonna say. We don't want this to be too dark. We want it to be dark enough where you can pay attention to what's going on, so that you know how to talk with your clients and your prospects about the large picture. A lot of them want to know the large picture, and so we're hoping to give you enough of the large picture where you can talk to them about it. You can sound like you understand what's going on, and that you can then talk to them about how to manage that system. And so in this, there's opportunity for you. So in disruption, in chaos, there is always opportunity. And we're hoping to point out the chaos that's going on in the system right now, so that you're going to be able to think about it, and you're going to be able to find the opportunity that's in that chaos. I think things are going to get worked out. They usually do. And I think we're going to go on, but there is this sea change that is happening right now. And I am, just so you know, I am personally not, I am personally not discouraged or demoralized by the changes that are coming. It does mean that if you have persistence, if you have tenacity, you're going to be able to come out smelling better than some of the people who allow themselves to be demoralized. Okay, so some of the other things here are the heavy authorization requirements and denial rates. This is also leading to the pressure on the provider networks, and these denial rates and everything are going up because of the pressure that's on the carriers, and that is creating conflict between the carriers and the providers. And so right now, 16% of healthcare systems are planning to stop accepting MA plans within 2 years. I don't know if the system is going to figure out how to manage this. Another 45% of the provider networks, and these are hospitals, physician groups, pharmacies, are contemplating rejecting the acceptance of MA plans going forward, but they haven't made a decision to do that. Something else that's happening that's putting pressure on the carriers is that CMS is going to recalculate the star ratings. They call it the Tukey method. And what it does is it eliminates all outliers in the first quartile and the fourth quartile, puts everything toward the center, which means that some of the carriers who have received 5 stars because they have been excellent in one or two things, like customer service, are going to lose their 5-star ratings. Don't know who those people are going to be, but that's going on. And then this Change Healthcare cyber attack that occurred in February this year, it has taken down about a quarter of the healthcare system in the United States. That means that physicians and physician groups and clinics and pharmacies are not being paid. They're not able to pay their employees because they themselves are not being paid, and there's quite a disagreement between CMS and United Health Group, the parent of United Healthcare. And it was a United Healthcare subsidiary called Change Healthcare that suffered the cyber attack that shut everything down. And we're going to be looking at that a little bit more. But all of these things are putting the system into quite a challenge. Now, I did want to mention this. This is the thing that happened to us this week. The first draft of the new final rule, which is going to be coming out and is supposed to be effective on June 3rd, came out this week. And so I spent quite a bit of time looking at it, trying to make sense of it. The lawyer who wrote this thing, you can tell they've never been an agent. They've never been in the insurance industry. They don't understand how some of the terms in the industry are used, and so there's quite a bit of ambiguity in the stuff. Bob expressed lots of frustration when he was reading it. But anyway, so I'm anticipating that they will significantly rework some of the concepts before they come out with the final draft of the final rule. But I just want to talk about a little bit of the things that I'm able to discern in there that have to do with the intentions of CMS. So here's some of the things that I've taken away from it. They have decided that there is a lot of, I don't want to use too strong a word here. I should have thought of the word before I started this. I'm going to use the word corruption but that may be too strong of a word. It could be strong self-interest that compromises the interests of the beneficiaries. They see a lot of this in the system, especially in the way that leads are generated and the way that the third-party marketing organizations, the TPMOs that you see there on the page in that 1, 2, 3, 4, 5, fifth bullet down, you guys are all considered TPMOs, third-party marketing organizations, as agents. That's what you're considered. Anyway, and a lot of it has to do with the call centers and the advertising and everything. And there are more people enrolled now over the phone than there are enrolled in face-to-face. So there's going to be a greater coordination between 3 agencies going forward. It's going to be being implemented this year in 2024. And that's between the FCC, the FTC, and the HHS. There is a lot of concern about illicit contact. And they are going to be requiring much stricter written permissions from the beneficiaries to have their data conveyed to other TPMOs. So if a lead generator gets a lead and then he sells it to say 5 agents, the lead generator is going to have 5 written permissions from the beneficiary whose data was collected in order for that lead generator to give that data to the 5 different people, right? Currently, the system is that lead generator gets the lead. He then sells it to, say, 5 or 10 people, and he sells it to them, and then it's a race for them to contact. There's a lot of complaints going on. I know that it's something that I have to deal with all the time. People complaining to that about me, and I don't really, I haven't had anything really beneficial to say to them. So we now have a third category of data that is going to be protected, and it's called, and you can see in that second square bullet point on the screen, it's called personal beneficiary data. So this is data that is collected by a third-party marketing organization and is then conveyed to another third-party marketing organization. So someone collects a lead or someone gets a referral and they send it to some other person. So they send it to an agent who's going to be able to implement. There now needs to be written permission from the beneficiary whose data is being conveyed for that data to be conveyed. So now we have, yeah, Bob, you don't need to raise your hand, just jump in.
Well, one thing I wanted to jump in on was occasionally leads come in or an agent will have one of his clients moving and wants to send that client information to another agent to take care of. And this is one of the real gray areas that are being talked about, because if you have a book of business, you have someone who is leaving to go somewhere else, you want to take care of that client of yours, and many times you'll contact an agent in another area where you're not appointed to write. And so that personal beneficiary data to other TPMOs needs a little bit more clarification, I think. Back to you, Doug.
Yeah, so go ahead, Gene.
Just wondering how that is going to have an impact on outbound calls, because if we're selling data to whoever, an agent, and saying, hey, here's somebody that wants to talk about Medicare, are we allowed to make outbound calls? And one other point to that is I personally get outbound calls. I mean, they stopped last week after the end of the month, but I would get outbound calls every day, 3, 4, 5 times a day, somebody wanting to review my benefits. And if I allowed them to review my benefits, then they would do a live transfer to their call center so that it would register at the call center as an inbound call.
Yes, yes. So that's, as you know very well, that has been prohibited for years. And those call centers keep doing it. So these rules that they're putting in place are trying to attack that from an indirect point of view. But let me finish this other point here. And I think this is a big deal. So as I was reading this, these regulations this last week, CMS now is going to start using Title 18 of the Code of Federal Regulations, and Title 18 is crimes and criminal procedure. You can see that there in parentheses. So the way, Gene, I'm interpreting this is that for the very first time, CMS is not going to be relying on carriers, nor the FCC, nor the FTC to go after these people. The CMS is going to be using Title 18 to start going after bad actors in the Medicare field. So I don't know how that's going to look, but the statute that they keep talking about is the anti-kickback statute. That is where people who are involved in federal health care profit without following the rules, and the fines can be up to $100,000 and jail time can be up to 10 years. I don't know how long it's going to take CMS to come up with law enforcement arm. And so I don't know anything about this. I can't say, and I believe I mentioned this, I think I can see their intention. And so this will be a major change if it comes about, right? Where CMS is actually going to be going after carriers that pay, and we'll see this in a minute, carriers that pay administrative payments to street agents, carriers that pay large amounts of money to FMOs that can be construed as an increase in commissions. That's what they're trying to go after because it seems to undermine. And this is the last hollow bullet point here on this slide. So another big thing, and this is going to impact you all most directly, changes in the agent broker FMO compensation. I put in FMO there because I really can't tell what they're trying to do. As I look at the way that words are used in the first draft final proposal, I can tell that the way that the words are used changes throughout the presentation. And so I believe that what we have happening is that the writer just doesn't quite understand some of the way the words are being used in our industry. So I'm anticipating that will change. So that puts an ambiguity here, means that these things that I'm talking about are, sorry, someone's trying to get in here. These things that I'm talking about aren't totally clear yet, right? So all of us are trying to read this first draft and figure out exactly what's going on. But let me just tell you what I think is happening here. All of the many of the incentives that carriers have been using to change your agent behavior are going to go away. For example, the health reimbursement assessments. Those things are going to go away. They are considered an administrative payment, so travel is considered that, maybe compensation from your FMO or your carrier for the cost of a community meeting or things like that. Those things are all going to go away. They're going to revise the definition of compensation. the goal of all of this stuff is to make it so that the agent objectivity with respect to recommending plans from different carriers remains balanced, and there's no threat to the objectivity. They feel that the agents were swayed by that they wanted to write plans, for example, that had a higher compensation rate for the health reimbursement assessment. So if you could get the standard commission for writing two carriers, the carrier that paid you more for the health reimbursement assessment was going to win, and that was skewing the objectivity of the marketplace. So they're trying to eliminate all those things. So they're going to eliminate the entire category that carriers have been using of calling these things administrative payments. Now, they recognize that this may affect things, may affect the financial health of the Medicare agents. And at a time when the distribution system, the providers and the insurance carriers are under so much pressure, they seem to be trying to say, well, we want to keep the agents in good health. So what they're going to do is they're going to be increasing the cap amount that carriers are allowed to pay agents for new to Medicare, the fair market value, up to $100 this coming year. So there's going to be a substantial increase in how much you are paid for new to Medicare this coming year. But that's going to accompany the elimination of the health reimbursement assessment and all of those other things that have been considered administrative payments. For renew and replace, it's going to be the maximum cap of $100 for new divided by 2, or as they say, times 0.5. So you're going to see a healthy increase probably, unless things, I mean, this is not the final rule. This is the first draft final rule. But that's certainly their intention. I don't know if anybody has any questions about that. But... Okay. These next things here are going to be moving pretty quickly here because I got to make time for Bob here. Sorry, Bob, jump in. I just want to point out here that, you see that red square there? That's going to be very important to you when the questions come. So this is showing how many people actually switched during the last AEP. And I know that that's a point of stress. Agents don't quite know what to do, and so they spend a lot of time reaching out to the current book of business. And in this last year, only 13% switched. Now, that was occurring in the year before the great big sea change that I keep talking about that I think is coming this year. So the people who did not even shop, or they didn't even look at they didn't even want to consider new plans, was 56%. So they didn't look at any other carriers. They didn't want to talk to their agent. They just wanted to stay away from all that complexity as much as they could. Remember that red square. Remember another red square here. The number of enrollments that are facilitated by independent private Medicare agents is 58%. And you can look at this stuff, and I'm just going to rush. Bob, take it away.
You know, there was, Doug mentioned it earlier, there was a huge data breach at UHC, which went up the line to a health clearinghouse. Now, the health clearinghouse is kind of a central point that many of the carriers use. I understand it's even used for life insurance. Some people call it the medical record bureau. But this data breach at UHC, or United Healthcare Group, was the hackers demanded a huge ransom of $22 million. And from what I understand, UHC did not pay that ransom amount, if I remember from what I read correctly.
I heard they did pay it.
Oh, did you?
Yeah.
Either way, it's still ongoing because millions of healthcare beneficiary data was hacked, which has given those who are in the scamming business and can get into the dark web, they're able to get unbelievable amount of information. This hack affected insurance enrollment confirmations. It affected prior authorizations, claim submissions. I had a couple of clients of my own submit direct reimbursement from Aetna for some fitness stuff, and never came. They finally did some digging. I did some digging for them, and what happened was they were not sure. Aetna, the people who process that, because of the disruption or the hack, the data breach, they weren't sure what was authentic and what was going to a scammer. So a lot of those were turned away. And as I looked at it, it looked like to me the things that were being turned away is when people were asking for that full $1,200 direct reimbursement. And that kind of red flagged Aetna on processing those because it wasn't, $100 here, $200 there. It was all at one time. So it really disrupted that. I've had 2 clients now who have had to redo their direct reimbursement forms. And that I would hope that if Aetna stays with that benefit, they simplify that, because it's a multi-page document that you can fax in or mail in, and it's kind of a mess right now. So it's still ongoing. This hack involved hospitals, physicians and clinics, pharmacies. I had one. I went to pick up a prescription that I have at a new pharmacy, and they said they had to contact Aetna to make sure it was legitimate, because it was a very expensive prescription. So this thing not only affected hospitals, physicians, clinics, and all that electronic platforms, it's also funneling down to the beneficiaries. Next slide, Doug.
Yeah, and can I just remind everybody that in chaos, there's opportunity. So the agents that are not reaching out to help their clients through all this are leaving themselves open to you guys, right?
One of the things that has, what's the right way, given this thing even more legs to run, so to speak, is AI, because the scammers they're using the AI to scam people. So it's the fallout is with physician groups, again, hospitals. It's a mess, this thing, and it's ongoing. And it seems to me, as I look at things, there's conflict between CMS and United Healthcare. They're kind of pointing their fingers at each other to fix the system. And the CMS is saying, we need to, or the government's trying to figure out ways to get this thing fixed. They point their finger at United Healthcare. It's just a lot of mess going on here. And because of that, I think it is affecting the final rules that are coming out. Again, Doug said the first draft, and this first draft, as I read through it, was very confusing. And to me, it almost seemed as if they were enlisting the same people that China uses to write instructions to people in America on how to put things together. We've all had that experience. It's very confusing. But anyway, 20% of Humana's electronic transactions were affected. 25% of CVS, that's Aetna, their electronic transfers were affected by this huge hack. Again, they estimate, well, they haven't. They've just said millions and millions of records were breached on this. Doug, next slide. So one of the opportunities you have as an agent is educating your book of business. You know, one of the things that endears clients to their agents is how many times their agent actually reaches out to them and maybe gives them some education. I had a neighbor. I thought this was really interesting. This happened about a month ago. I had a neighbor up here where I live, and we're all pretty much seniors up here in my neighborhood. But they got a text message that was supposedly coming from a grandson who was in some legal problems down in Las Vegas and was at a jail. And he, according to the text, I talked to my neighbor last night to get a little bit deeper details. The text said that they weren't able, they had called, but no one had answered. So they were sending a text that was asking for some bail money. And one of the things in this text was they were telling their grandparents, please don't call my parents because they'd be awfully upset with me for doing this. Well, this neighbor of mine had enough sense, I guess, or it dawned on him, I'm just going to call my son and in a roundabout way ask him how my grandson is doing. They didn't, and they said, well, he's downstairs in his bedroom. I think he's asleep. I'll go check. And sure enough, the grandson was in his bedroom asleep. So we just need to take an effort. And I know your beneficiaries, your clients would express a lot of gratitude for any education that you can provide them. The other day, I got one from Mountain America Credit Union, where I have a savings and checking account. And it looked as official as anything could look. And I even hovered over the person who sent it. And a lot of times you'll see some crazy email address, but this one actually said, it said Mountain America / something. I can't remember what it was. Well, raised enough red flag in my mind that I called Mountain America about it, and they immediately said, we've been answering the phone all morning long regarding this email that you got. It did not come from us. And a couple of things are scary about these. If you have a client who thinks, well, I'll click on this to see a little bit more, see if I can determine if it's a scam. That's the worst thing they can do, because if they click on a link, that could do all sorts of harm to their privacy on their computer. But I know your clients would appreciate some education on some of the things that are going out. This one on the right, where you see scam alert, this came out from Social Security. And you know, if you have a electronic monthly newsletter, you could use that to educate your clients regarding the scam and maybe pass on the scam alert from Social Security. But I think it's an opportunity for you as Medicare agents to demonstrate to your clients, number one, how AI scams work, but more importantly, endearing yourself to your clients. Next slide, Doug. So post-enrollment services opportunities, you truly can become a valued resource to your clients. I have a very, very small book of business. I can't imagine what it would be like if I have a large book of business, because I probably get 4 or 5 calls a week from my small book of business clients asking me questions. And I try to, when I set up my contact list, I always make sure that my clients, they come up on my phone with their name. so I think it's a real opportunity, post-enrollment services, to really build loyalty with your clients. And I think well, I had one client tell me right off the bat, he said, you're my go-to resource. That's what you should be aiming for as an agent to your clients, that you're the go-to resource. I know sometimes that can be a hassle. I had one client call me, hey, you're my go-to guy. I'm calling you because I've got a brother in Illinois who's having trouble with pre-authorizations, and what should I tell him? And I had no idea who the insurer was, who the carrier was. But I did give the client, make sure that this person knows that there is a appeal process. They just need to contact your carrier, and they can find out the appeal process. They can even file a grievance with CMS. So what can you do? I mean, you need to treat all service calls when people call you as an opportunity to build loyalty. Now, when you do that, you become a hero to them, and it's a good way to nurture referrals for the future. Doug, next slide. Ideas for generating referrals compliantly. I know all of you get referrals. I'd like somebody to jump in, any of you to jump in and share with us a way that you get compliant referrals. I'm looking at you, Alan. I'm looking at your picture. I know you get referrals.
Hey, Bob, I've got something I could share.
Okay.
Years ago, when I first got into this industry, we were switching over hundreds of thousands of people from group plans that were closing to Medicare. And there was a lot of concern about what is Medicare, how does it work, how can the government afford to give me a zero premium plan, a lot of questions. And I found that if I took a little time and explained it to the beneficiary, how it works, how the government pays money to the carrier in lieu of the money that they would have kept with a regular supplement plan. I went through the process of how it works and explained it to them. And every single time I did that and took the time to explain to them how that works, they would say, wow, nobody's ever told me that before. And ultimately they would say, do you mind if I have my sister, my brother, my cousin call you? And I would be like, no, that's fine. I'd be happy to go over their situation as well. So just by providing the information, as you guys have been talking here, helping them understand and feel good about the relationship and the information, I think is a great way to get referrals.
I think it is too. I think, if you are not doing a newsletter, you should really consider using the easiest way to do it is using not text messaging, but emails to do at least a quarterly newsletter. And if you do that, you could have a section explaining dangers of AI, how to respond to denials, what the appeal process looks like, what recourse they have, helping them read the explanation of benefits. You can get a lot of mileage out of a electronic quarterly newsletter. You could even put something in there that would be not even health related, but something that seniors. I know one agent who his wife has a little corner of their email that she puts in a recipe every time, and just little things like that can really build client retention and clients referring people to call you if they've got a question. All your clients have friends who will ask them questions about their Medicare. And if you could instill in your clients, hey, have them call me. I'm more than willing to spend the time with them. There's a lot of questions out there about dental, hearing, and vision benefits. I find a lot of calls come to me about OTC and healthy living. Take the opportunity to really be of service. You know, one thing a lot of agents forget to do, and that is the $15 gift per quarter. You know, down here in St. George, most of the movies have Tuesdays as a discount. You could send out some sort of a ticket or voucher for the movies for Tuesdays, because you would definitely be under that $15 per quarter thing. I've gotten free tickets in the past to a couple of things at Tuacahn that I've distributed to a few clients, and they really like that. And it builds a lot of loyalty. Next slide, Doug.
Okay, this is my slide, right?
Yep.
I'm going to go very fast here, guys, because we're approaching in on the hour here. I don't have a red rectangle around this, but it will be important to you at the end of this meeting when Nancy emails you. Let me just quickly talk about the fact that there is a special 5-star enrollment SEP, and that when you're moving someone over, that there is that SEP. So you have one SEP. You have a 5-star SEP. You have one of these over the year, and you can use it one time. As soon as you use it to enroll in a 5-star SEP, it goes away. And then let me just mention, if you start doing DSNP or you're already doing DSNP, if you're an expert at this, I think Colette's pretty much of an expert at this. You can actually talk with the carriers. You can call the producer helpline, the agent support line, and they should be able to help you with the eligibility level. Now, a challenge is that a lot of these carriers were actually getting their stuff through the Change Healthcare, and so that this is one of the things that was compromised. But they're bringing it back online. I think it's going to be back online for everybody here pretty quick. Bob?
So again, you know, be familiar with the DSNP rules. They have to have Medicaid with Medicare to get the DSNP. I had a person call me, inbound call the other day, saying, "Hey, I know I'm below the FLP, federal poverty level. Can I get into a DSNP?" And it's like, well, unless you have Medicaid, you better apply for Medicaid. See where that takes us. Again, once per quarter. An AEP in quarter 4. CSNP, you know, we haven't traditionally had a CSNP in Utah, but we have one now. So again, you can move people with a CSNP anytime if they have a targeted chronic condition that qualifies. ISNP, we all know that's institutional. Again, someplace where a person has 24-hour nursing and medical care. Agents must be specifically and invited and authorized by a carrier to get involved in the ISNP. I had one of those last year and had to coordinate that because they typically, in an institution, they have docs coming in or nurse practitioners coming in who may or may not be on the in-network roll call, but they'll make arrangements for that. They'll make exceptions for that. Next one, Doug.
Yeah.
Market trends. Yes.
Real quick on that. If for some reason you're in a care center and you've got the institutional, when you leave there, maybe you got well, you do have another special election when you leave.
Thank you.
Colette raised her hand, Bob.
Yeah. Yeah, I just wanted to bring up, so with like the DSNPs and the CSNPs, I offer like a courtesy for, you know, the people that I take care of. I'll put in my calendar when I know their Medicaid reviews coming up a couple months before, and I'll just reach out to them and say, hey, you know, your review's coming up. We do want to make sure that you get your paperwork into the state in time so we can keep them in that DSNP so they don't lose it and you have to re-go through everything, because they do the renewals either once a year or every 2 years, depending on the Medicaid level that they have. So that's a way to keep them sticky as well, you know, in your book of business, and make sure that they can stay in the plan. Also with the C-SNP, you need to fill out, and well, the doctor has to fill out that paperwork qualifying them that they have that chronic condition. So I just prep them ahead of time, and I'll get them and email them the physician's paperwork that needs to be filled out ahead of time. So they have it for their doctor, and they can call as soon as we do the enrollment, because they only have so many days to get it into them to verify that.
A great idea, Colette. Thank you so much for that. That was
You're
great.
welcome.
That was a great idea. You know, half of Medicare eligibles now are in MA. However, we have seen over the last fourth quarter and first quarter of this year, CMS is reporting there's an increase in Medicare supplements. You know, there was a massive amount of people, can't think of the word, using their Medicare benefits in fourth quarter and first quarter has continued. That trend's continuing. But anyway, you know, what Colette said is an excellent way to build client loyalty. And that word gets around. They beneficiaries, clients talk to each other, even in a D-SNP or an I-SNP. If you do things in a very fantastic way, staff, I've had this happen, staff at the I-SNP have called me and made connections for me there. So again, Colette, that was just a wonderful idea.
Hey, Bob, we've got 2 minutes.
Okay, real quick. A couple of weeks ago, I was invited by some agents to go with them to a group. And they enrolled 8 people at this group meeting, and got many more potential clients. They're just working the clock on that. Next one, Doug. New rules. CMS is considering new rules for carriers and providers. You know, again, this is a first draft that we've seen. Clarification will come from the carriers, just like it did for the call reporting. The carriers are going to be interpreting a lot of this and passing that down to us as agents. So a couple of things. You can now, one of the proposed rules is you can have business reply cards at educational events, when before you could only hand out a business card if it was requested. They are talking about a lot of confusion came up with the disclosure of number of plans available. That's created a lot of confusion, which has translated in complaints to CMS. They're re-examining, contacting your own book of business, some rules about that. Again, it's first draft. One of the other things that they're considering is that cooling off period, 48 hours between community meetings and enrollment. They're looking at doing away with that. I think that not only benefits us, but it could possibly benefit call centers. Next slide, Doug.
Yeah, that was a 12-hour cooling off period, not 48. Sorry about
Yeah,
that.
you're right.